Good afternoon, everyone, and welcome to this final sessions of Ideas Liberalism Conference 2021. My name is Ali Iskandar, Communications from Ideas, your MC for today. Before we begin, please allow me to begin with a short housekeeping announcement. At Ideas, we are committed to provide a safe environment for all parties, both internal and external, to work together. Ideas has a policy of zero tolerance towards sexual exploitation and abuse. Everyone here today is responsible for making this event a safe space for public discourse. The battle between personal liberty and community interest or security has been a never-ending one since September 11, 2001. These days, however, questions are being asked again on how we balance personal liberty vis-a-vis the public good. For this session, I would like to invite Tricia Yeoh, CEO of Ideas, to moderate the last session of our two-day conference, COVID-19 Vaccination, Balancing Personal Liberty and Community Interests. The floor is yours, Tricia.
All right, thank you so much, Iskandar, and a very warm good afternoon to all of you, especially our panelists and also whoever is able to join us on this Sunday afternoon. This is the last session of a two-day liberalism conference that Ideas organizes annually. We are in our sixth installation of this annual conference in which we discuss and debate issues on many different topics. We try and link it with what's currently happening. So we usually have panel discussions on economics, on politics, on social issues. And it's also one of those avenues where we have tried to take the discussion on a little bit more of a philosophical level. Our typical work is on public policy, of course. And so the public policy link with philosophy, of course, is not something that can be separated. And this is something that we do try to explore. So today we're going to, in this afternoon session, discuss something that is really relevant and current. Our panel title is the COVID-19 Vaccination, Balancing Personal Liberty and Community Interest. As introduced by my colleague earlier, the question is, how do we actually strike this balance between the rights of unvaccinated citizens to enjoy everyday benefits and the need to protect public health? Must we undermine personal liberty to achieve community interest, or should it be the other way around? And I think when we planned this session, we didn't expect there to be such a big debate over what's already been taking place. So very, very recently, as recent as last week, our health minister, Khor Jamaluddin, basically said that we will make life difficult for you, anti-vaxxers. And this was responded to by several leaders. Opposition leader Dato Ibrahim labeled this approach as arrogant and saying that there should be greater public education about vaccination rather than taking this very forceful approach towards Malaysians who refuse to receive the COVID-19 vaccination. Of course, Khor then responded saying that this is a stand that is good, it's firm, and the government has already provided enough explanations about the vaccination. You know, he said that we've already tabled all scientific proof on the effectiveness of the COVID-19 vaccine from earlier on, and we continue to provide explanations. So this is really something that is spot on when it comes to debating and discussing liberalism, because in liberalism, we all try to measure what's the context, what's the extent to which government's arms should stretch, and to what extent personal liberties should be exercised. There's no right or wrong answer. I think this is the fun of this discussion, where we really want to draw out and tease out the subtle nuances, but hopefully in a systematic way for us all to discuss. And today, I have the pleasure of inviting three very prominent speakers who have been also very prominent and vocal throughout the last 2 years of our public health crisis. And let me introduce them one by one. So first we have Professor Adeeba Kamarulzaman, who's currently the professor of professor in the Department of Medicine in the Faculty of Medicine of University Malaya. She joins us all the way from Germany, actually. So she's actually in Berlin right now. Prof. Adeeba graduated from Monash University, is trained in internal medicine and infectious diseases from Monash Medical Center and Fairfield Infectious Diseases Hospital, Melbourne, Australia. She has been very prominent in Malaysia in many, many areas. She's a council member, executive council member of the International AIDS Society. She was a member of University of Malaya's NIPA investigative team. She is the first recipient of the Advanced Australia Global Award in the category of alumni in 2012. And in 2015 was honored with the Doctor of Laws from Monash University. She has been featured in The Lancet and Science publications, and most recently was appointed to be part of the National Recovery Council. And so she's also very familiar with what the government has been doing with regards to trying to combat COVID-19. And I think we'll have very fascinating views on the vaccination. Second, we have Dr. Hartini. So Dr. Hartini Zainuddin is a child activist, and she is very active in many areas. She's the co-founder of Yayasan Chowkit, has served as the head of advocacy and funding, as well as outreach program in Chowkit. She is the vice president of Voice of the Children, and she has been in various task forces, child protection policy training. She is a great advocate of issues surrounding trafficking, stateless children, Malaysian adoption system. And in her previous life, she was doing a lot of work on the ground in New York as well, where she did her doctorate in monitoring and assessment from Columbia University. Dr. Hartini also is a member of the National Recovery Council, and so is also well placed to talk to us about what the government is doing, but also has very valid on the ground experiences. Last but not least, I'd like to introduce my friend, Dr. Khor Kheng, who is currently an associate fellow at Chatham House. And he is trained as a doctor. He's a Malaysian physician, has worked in public, private, nonprofit, and think tank sectors. He has held fellowships at ISIS Malaysia and United Nations University International Institute of Global Health, has written a lot. He has contributed a lot of columns, a lot of public pieces, also within the COVID-19 space over the last 1.5 years. In fact, that's how I know him only recently, last year or so. And Dr. Khor, if you can also turn your video on just to say hello, and then later we will invite you to, yes, okay, so these are our 3 distinguished panelists today. We will go in order of my introductions. I'll give each speaker between 10 to 15 minutes for their first intervention. And then after that, what I'll do is ask some questions, and then we'll take some questions from the floor. So I look forward to this discussion. It's something that's close to my heart. Vaccinations is going to be the primary, or has been dependent on primarily by governments around the world, not excluding ours, as the one way for our countries to get out of this, not just public health, but also economic crisis. So it's really important to understand where we are on vaccinations. And yeah, like I said in the introduction, how much can we actually force people to take the vaccinations, especially as we're considering future potential waves of the pandemic coming upon us. I think right now, Malaysia's gone out of these waves, and I think we're a little bit in a comfort zone now because we're able to travel across states. Our numbers have declined, well, significantly compared to, say, like what was just 1 month ago. But what happens next, right? And I think thinking about these things ahead of time, planning it in our heads, will there be booster shots, and will the booster shots be made mandatory? The government, for example, now makes it mandatory for children to get vaccinated. And if you don't get vaccinated, you can't go back to school. So I think there's a lot of things to unpack there. I think we've not been able to really express our views openly or freely enough. And I really hope that this will be the right forum to do that. So without further ado, please let me warmly welcome Prof. Adeeba to share her views with us. Prof. Adeeba, over to you.
Thank you very much, Tricia, and everyone. Good morning from Berlin. I was just complaining to Tricia and Tini about how crappy the internet here is. So I'm on the phone and I might drop off anytime. So that's just a bit of warning here. I think, as you have rightly pointed out, we are in a major crisis, and some of the uncertainties in terms of we've just come through a really catastrophic crisis, particularly in Greater Klang Valley, in Penang, and in Kedah, and in Sabah, in terms of very large numbers of people getting infected. The health system was completely overwhelmed, both in the public health sector as well as the hospital sector. Large number of admissions, horrific pictures, deaths, etc., etc. And in many ways, things could have got a lot worse had we not, embarked on a major vaccination program beginning in February of this year. It was unfortunate that at the time the Delta variant landed on our shores and began to the surge in May, June, July, August. Our vaccination rate at the time was only around 50%, but as soon as we kind of reached a significant proportion of the adult population being vaccinated, you saw that it coincided with a rapid decline in the number of new infections and hospitalization and deaths. So apart from intense study on the vaccine in clinical trials and in real life in countries that have rolled out vaccine in a major way since December of last year, namely UK, US, Israel, etc., we ourselves have experienced the real world effectiveness of vaccine. There is absolutely no doubt that the vaccines work, okay, particularly in terms of preventing severe disease, hospitalization, and deaths. And we know that from the large clinical trials, and we know that from real world observational studies in countries that have rolled out millions and millions of doses of vaccine. And now we ourselves have experienced it in Malaysia, how effective the vaccines are. We saw that in states where the vaccine rollout lagged behind, say, Greater Klang Valley, for instance, Johor and Kedah and Kelantan now, the numbers continue to rise, right? So that's number one in terms of both the scientific data in terms of the effectiveness of the vaccines, as well as real-world efficiency of the vaccine, including our very own experience of the horrific time we had between May and September before the coverage of vaccine reached 80-90%, and we then saw the sharp decline in the number of cases. So with that, we have now, as you mentioned, enjoyed the luxury of being able to return to some form of normalcy, being able for millions of people to return to work, to look for work again, and most importantly, children and people at universities to go back to school and to go back to having a more effective education, I should say, right? That's really, really essential. So to me, there shouldn't be any doubt at all in terms of the need for vaccination in both the scientific data as well as the real world data should convince everyone about this. Now, why is there such pushback among some quarters with regards to having this vaccine that not only protects us, saves our lives from severe COVID or from death, and equally importantly, is letting us return to some sense of normalcy instead of being under such major restrictions that has essentially done a lot of damage economically, mentally, and socially. So part of the problem, I think, is at the speed at which the vaccine has been, put into the arms of billions of people around the world. I think surveys have shown that fear still is one of the reasons why people are hesitant to have the vaccine. So, and particularly the pushback against the mRNA vaccines. You still hear people saying, but, these vaccines are new, we don't know enough about it. The scientific data is incomplete, the clinical trials were rushed. Now, all this is actually not true. First of all, the mRNA technology is not brand new. It's actually been around for more than a decade with, studies for vaccines for other diseases as well as for cancer therapeutic vaccine. So that's number one. It's not something that, a bunch of scientists cooked up just as the SARS-CoV-2 or the COVID-19 pandemic came about. Secondly, the reason scientists were able to really put this vaccine out in under a year, which is nothing short to me of a modern medical miracle, is because A, the platform is already in existence. B, the coronavirus itself, of which the SARS-CoV-2 is a family of, is being studied intensely because of the original SARS virus, the MERS virus, which are all coronavirus. So there are groups of scientists all over the world studying the virus, designing this mRNA platform that came together with huge investments from countries, from philanthropy, from pharmaceuticals itself that gave rise to the mRNA vaccines. Similarly with the other vaccines, because of the huge investment that came in, that you have both the mRNA vaccine, the Oxford AstraZeneca vaccine, and of course you've got the inactivated vaccines, the Sinovac, etc., which rely on very traditional way of making vaccines. And each step of the clinical trial, the phase 1, phase 2, phase 3 studies, which are essential before you allow any kind of medical therapeutics to be given to someone, each step was done, right? And the reason why it was able to be done in under 12 years is again because of huge investment, and so in the past, when you've got phase 1 trials done, you wait for the results, but only when you get the results do you then start to look for funding. Do you then design the second phase? You then design the third phase. All this was done in rapid succession because essentially the funding was there to do it instead of waiting to do one step at a time. So there is absolutely no doubt that, you know, in terms of the scientific rigor as well as safety were followed, but there remains doubt amongst certain quarters, and which brings me to the third point I want to make. And the reason for many of these doubts is none other than social media. Right? In the past, people don't have access to social media where people can propagate misinformation and disinformation that all of us have experienced, right? Within seconds, someone sends you some, you know, inaccurate information, and then it gets propagated within seconds to 10, 20, 30 of our phone contacts, you know, that then sows doubts into some of the, you know, the accurate information that one should have. So I think these are the three main issues. And then, of course, you know, what Dato Sri Anwar Ibrahim said in terms of providing information, and our health minister said enough information has been given. I think the issue here is, you know, scientific communication can be very problematic. I think we scientists, doctors, sometimes don't do that in a effective way in terms of how we communicate the science. So if you recall, very early on when the vaccines first were released, I think we were very obsessed with describing the highly efficaciousness of the vaccine, you know, the 98% efficacy of the Pfizer-BioNTech, the Moderna studies, and but we didn't, and that was how the studies were designed, to reduce severe disease, to reduce mortality. But it then sowed doubt about the transmissibility, and I think how the vaccine reduces transmission, which was something we couldn't really answer because that wasn't designed, how the studies designed. And scientists being scientists, you know, stuck to what is known in science, and it really needed for the real world rollout of the vaccines to then be able to understand how it reduces transmission. So, which then gave an opportunity for detractors to say, well, you know, but the vaccines don't reduce transmission. And so what good is a vaccine if it doesn't reduce transmission? You know what I mean? So, and another example of how it allowed doubt to be sown is, again, in how, this is certainly not faulting the clinical trials, but that's just, you know, how clinical trials are done. And usually it excludes pregnant women, pregnant and lactating women. So we also didn't have results from the clinical trials to say it's safe in pregnant women, pregnant and lactating women very early on, until it was then given in real life, and you know, those who received it are followed up, and we know that it's safe in pregnant women. In fact, it's essential that pregnant women have the vaccine because they belong to the groups at risk of severe disease. So once again, it gave the ability to then sow doubt about the safety of the vaccine in pregnant women, exactly the group that needs the vaccine. So that's the background in my view of how the intense debate around the safety of the vaccine, how I think the role of social media in propagating misinformation and disinformation, how we ourselves, scientists and doctors, have not done a very good job of reaching out to the masses in terms of really overcoming some of the uncertainties that exist, and which provides the opportunity for those who want to propagate misinformation, disinformation to flourish. And the thing is, the hesitancy, I hesitate to call anti-vax, because I think the real anti-vax form a small proportion of the people. I think there's possibly still a large number of people who are hesitant, who may not have been reached with the accurate information in the way that they understand. My people in Kelantan may not, turn on to ideas today, some, in rural Kelantan to understand the discourse. So, you need to reach them in language that they understand, in terms that they understand, to convince them. Right. So I think that's one of the things that we need to improve on. Now, in terms of making vaccine mandatory, or ensuring that as many people receive it as possible, as I said, we have an extremely effective vaccine that not only saves lives, reduces severe disease, allows our hospitals to return to normal, to look after the other non-COVID patients who've been neglected for the last 2 years. It's really frustrating for us, healthcare professionals, to have groups of people who turn around to say, no, thank you, we don't want this, for reasons that, in our minds, don't make much sense, right? So, as you alluded to, Tricia, it's first and foremost, of course, is to protect the individual, right? And from severe disease, from deaths, and from hospitalization. But the other role of the vaccine is to protect those who may not be able to receive the vaccine from severe disease themselves, and also to protect children who we have not vaccinated, right? So the fewer the number of people around that the virus can infect, the less the vaccine is not 100% effective. There will be people who
Prof, hi. I think there are some problems with your internet.
Having less number of emissions.
I think we'll need to mute you for now. Maybe someone from our side, Iskandar or Sally, if you don't mind muting Prof. Adeeba, we'll come back to her later. She did say that she has internet problems dialing in all the way from Berlin. So one of my colleagues, please mute her. What we'll do now is we'll go on to the next speaker and maybe wait for her to come back. But I think Prof. Adeeba, hearing her talk for the last 15 minutes about all the issues and the challenges that we've been through, it just brings me back to the memory of the last 8 months or so. I think it's been a really challenging time. I think all of us personally knew friends or maybe even relatives who were very doubtful about the vaccination. Not only were they doubtful about the vaccine as a whole, but I think the more challenging one for me was when people believed that they had vaccine choice, right? So there was a lot of vaccine hesitancy over certain kinds of vaccinations. Some groups of people were more predisposed to taking perhaps the non-mRNA vaccines, and some were more predisposed to wanting to take those mRNA ones. And so then descended into this whole flux of information, a lot of information, and information which lay people find very difficult to decipher, because it's about science, it's about these very complex developments of how the vaccines are actually formulated, and also there's this other conversation now that's happening about children, right? So like, should the children be vaccinated? And of course, what happened very interestingly was that because people actually dropped out from the signing up so basically the sign up rate dropped when there were news of these blood clots taking place in other parts of the world. And so this allowed for this opt-in of the AstraZeneca vaccine. If you can recall what happened, like it was just in May, but it seems so long ago now. So just trying to unpack all of that. And earlier on, just before we started the conversation, I think Dr. Hartini, so maybe this is where you can jump in. You were talking about how, some of the reasons that people give to choosing not to vaccinate themselves, that they're not necessarily untrue, or you can actually understand some of the reasons that they're providing, right? So I think just to what extent can we exercise our own choice when it comes to vaccinating ourselves, but at the same time recognizing, like smoking, sometimes there are negative externalities as well. Your choice affects somebody else's public health. So maybe, Dr. Hartini, we'll go straight to you now. So you have 10 to 15 minutes. Go ahead. Do you want to share slides? Just let us know.
Yeah, sure. Just the slides only because they're prompts, and because, like I said, I'm going after Dr. Adeeba and going before Dr. Khor, and I'm not that kind of doctor. So the work that I'm sharing is obviously very, very grassroots and very NGO focused. But at the same time, I also wanted to give my point of view, working as a consultant for the Malaysian Red Crescent Society, which is part of the International Federation of the Red Cross Red Crescent, and also as the temporary focal person looking at migration. So I'm actually looking at vaccine hesitancy from that point of view, although I will address the issue and go further into what my friends say, and they're not necessarily anti-vaxxers. They just have a lot more questions and have read up a lot of research that we may or may not agree with, right? So yes, if we could move to the next slide. Just in a nutshell, because it's more for me as prompts. So we've got all this data that's being generated, collected, analyzed in response to COVID-19. And, we've been told over and over again that this is a necessary step, collecting the data to fight the pandemic, that actions taken in emergencies often have long-lasting repercussions, and and we need to find technical solutions, and we need all this data, and we've got all these people, right? So we were told over and over again, data is important, and everybody's data had to be taken, right? We have MySejahtera, we have everything else. Next slide. So the dilemma, as you mentioned, Tricia, is the civil liberties, right? So it's often portrayed as a necessary sacrifice in the fight of COVID-19. And experts, we've been hearing all this talk, especially on social media as well, the whole law, public health, private policy. We've had discussions even with the work that I do at Malaysian Red Crescent, talking to IFRC, ICRC organizations, UN organizations about the right to privacy and how important data privacy was, and what do we do, especially in situations where we're asking migrants to get vaccinated and advocating for migrants and undocumented communities to get vaccinated, right? So what would you be willing to give up for your individual rights for the sake of the common good? Would you be willing to risk your life basically in Malaysia, especially if you're a migrant or refugee, knowing that there are conflicting policies in place that actually threaten to detain you if you step forward, right? So this is the situation. It's not just the anti-vaxxers who have a choice on whether they want to get vaccinated or not. You also have migrants and marginalized groups who may or may not want to be vaccinated, who, as Dr. Adeeba said, may know enough or not have enough information, but also are afraid physically of stepping forward, knowing that the authorities might be there to arrest you. So this is the other side of the picture. Next slide. Next. Already we talked about disinformation and misinformation. There are certain agencies within the government who has threatened to use the data. Oh, can you go back? Has used to use the data collected to actually arrest migrants and undocumented irregular migrants and communities as well. And you've actually seen raids happening from last year to this year, even before vaccination took place. Vaccination hesitancy among marginalized group is real because you see these raids, because you know this is happening. I mean, 3 weeks ago, there was another raid. There were raids in Sabah, right, where, you know, adults were taken and children were left in charge. So how do you expect these communities to step forward? Then there's a language barrier and, you know, a million of other reasons why people are not stepping forward. You know, migrants and undocumented migrants as well don't live in silos, yeah? They live side by side and married into Malaysians. So entire communities are not stepping forward for whatever reason, misinformation, disinformation, no education, no one's coming to them, no one's telling them what to do. So, you know, many of the groups are actually going underground. So it's eroding public trust. It's eroding trust amongst communities and NGOs like mine. It is making it very difficult for organizations like the Malaysian Red Crescent, who has the mandate from the government to vaccinate marginalized groups, including those who are bedridden, etc. and stuff, and migrants, to go out and get them to step forward. Because of this misuse of data, you've got one agency saying, oh my goodness, if you step forward, we may or may not use the data on MySejahtera to round you up. Then you have, you know, misinformation of data collected saying this many migrants were infected with COVID-19 during the month of May, June, July, and then posted on Facebook. So it creates and perpetuates more fear. No one's stepping forward because of this. Next slide. So the question then also, I think, when we discuss this whole vaccine hesitancy, is the fact that we need to look at the question differently. If you want people to step forward, you have to frame it differently. I mean, we should, and this is what Malaysian Red Crescent and the other groups working with migrants and marginalized groups are doing. They're reframing the question and looking at it differently in terms of looking and weighing the specific kinds of information that health officials need to do. You don't need people's actual addresses. You don't need people's actual phone numbers to give to the government. You can give certain information, general information, and then code it so that it's internal data that you can use. And you then protect the very beneficiaries from the fear of detention and the fear of arrest. And so then it becomes less intrusive. Then you have an alternative. Then you can slowly persuade while you do education, while you do you know, the advocacy at the same time. And especially in marginalized communities and stuff, this language barriers, the conflicting policies, like I said. And, you know, being part of the RCCE movement, which we have weekly meetings, RCCE being the risk communication amongst marginalized communities, right? And we have weekly meetings with UN organizations and the big NGOs, just trying to figure out how to translate information, how to reach out to the different communities, including those in Kelantan with Orang Asli. How do we, you know, ensure that we sort of address vaccine hesitancy? How do we reassure them that, you know, they will not be arrested if they step forward? Trying to come up with an alternative app that can be used to collect data and still keep people safe. These are some of the things that we're still working on months and months down the road. Next next slide. Next slide. Oh. Can we move to, okay. So, you know, we had this whole discussion in the Malaysian Red Crescent working on migration with ICRC on data privacy. So these are some of the questions that we asked, right? That we need to ask. Does the person have access to due process to challenge the intervention? If not, you shouldn't be doing it. Is the measure arbitrary or discriminatory? If it's discriminatory, you have to think of another way. If public health and privacy rights do not heed to, to be in opposition because of the stigma surrounding the disease, and what do? How do you change it, right? How do you design your data collection framework so that you address all these issues? And these are serious questions, right? Especially when working with migrants and marginalized groups. Next. This is one of the things that we need to address, and this goes back to the whole issue on your right to privacy. Consent is key. You cannot force anybody to be vaccinated if they don't want to be vaccinated. That's what we learn with the Red Cross, Red Crescent movement. You can't force anyone to do this. You give them motivation, you try to persuade them, you answer as many questions as you can, but if they don't want to do it, you can't force them. That's what we've learned. With that, we also must recognize that the misuse of data may result in violations of privacy obligations, and that's why it's going to take a little bit longer with these marginalized groups. And that there are international and regional legal frameworks as well that will show you how to sort of work with communities, because Malaysia isn't working in isolation. Other countries are facing the same issues as well. And that the right to data protection derives from the right to privacy. That's what we've learned. So this is, again, call for debate later in this discussion. Next slide. Moving on. So Malaysian Red Crescent has come up with their own data collection framework. We have reached out to all the vulnerable groups. We include them. We don't segregate them. We don't isolate and just say we are vaccinating migrants or we are vaccinating refugees. We are vaccinating everyone to ensure, and this is the big picture, that no one gets left behind, because we have to vaccinate as many people as we possibly can. Next. So just to give you an idea of what Malaysian Red Crescent is doing, there's mobile vaccination. So they literally go into communities and they do, 20 to 30 people a day, vaccinate 20 to 30 people. They do a pre-registration through Google form, through working with community leaders. This has been months and months of work that we've done this, yeah? So we actually engage with the communities, they go in, they talk to the leaders, they get the leaders to buy in, then you get the community leaders to persuade everybody else to come up. So you have Google Sheets, and line listing ready. We've looked at best examples from other countries, Maldives being one of them. We work with everyone, including MyVest and CITF. Very minimal data, just name. If you want to use a pseudo name, you can, but we know we have the data in Dell and we're not giving it out to the government, right? We just give them the bare minimum. We try to get them on MySejahtera, especially if you're a registered refugee, so that's sort of easy, but the difficulty comes when you vaccinate stateless groups in communities in Sabah, say, for example, right? And if they don't have a smartphone, use this white card, which is on the next slide, that was used in Adeeba's familiar with this white card that was used in Klang Valley. The next slide, so it looks like this. That's basically how it looks like. You just write down the thing and you have this thing and you do first code, second code, nothing's collected, you bring it on the day of your vaccination. Next slide. So how do we document and definite? These are the numbers of people that we vaccinated so far in Sabah, and we have vaccinated undocumented. So 28, 29 of August, we did Penarod, we did all these different places, Teliport, Pulau Gaya, Numba, Lad, Atu, Sandakan. So we are vaccinating them in Sabah. We're going to Orang Asli groups. We're looking at different refugee groups in Cameron Highlands, KL, Klang Valley, etc. Next. And that is it. So, in a nutshell, which, I'm looking forward to having this discussion with Dr. Khor and Dr. Adeeba, it's not just the anti-vaxxers. A lot of it is also because they can't step forward. And that's basically what I wanted to say. So thank you very much.
Thank you. Thank you so much, Dr. Hartini, for sharing this really on the ground experience of migrant communities, stateless people in Sabah. Yeah, so many of them actually will not have access even if they want it, right? So I think, when it comes to government regulations and laws of restricting people from accessing certain services, if they're not vaccinated, like what are the implications there? if they want to do that, are there ways, or could there have been ways of doing that better? I think definitely the whole treatment of the migrant communities and stateless people, that requires like a whole conversation of its own, because it's a very different treatment, right, that they were given compared to treatment of Malaysians. And so even the discourse around vaccinations and like what do you access in terms of public services, I think that like requires a very different conversation altogether. But it's really interesting as well, like the point that you brought out about the data privacy issue, because this is something that many have raised. Well, not that many, but I've seen this point being raised often enough on social media, talking about the fears surrounding MySejahtera. And we know that MySejahtera app is not as efficient an app as it could be. And there are reasons for that as well. I think we all suffered those consequences, and we were booking for the second round of AstraZeneca. The thing kept crashing. And what makes of all the data that's going to be collected after all this? And do we actually have, I think this goes into a different level of discussion about laws and regulations surrounding data privacy. So Malaysia does have a PDPA, but has the technology caught up, right? So we're collecting all of this, and are there restrictions as to what the government can or cannot do with the data in terms of tracking individuals? And we know, for example, that freedom of expression and these other civil liberties area is that Malaysia doesn't have a good track record as far as those are concerned. So when it comes together, when all of the data are amalgamated, are brought in together, what do we do then? So great, I'm going to leave this to Dr. Khor to address. So Dr. Khor Kheng, you'll have the next 10 to 15 minutes, and then I'll probably spend a bit more time on you because you need to leave shortly. And hopefully we'll get Prof. Adeeba back, who is probably suffering poor internet connection. But Dr. Khor, the floor is yours, all yours.
Sure, thank you very much for having me. I would like, in the spirit of my friend and colleague, Dr. Hartini, maybe share one slide as well. So hopefully that will guide the conversation. So thank you for allowing me to share my screen. And here it is. And I think you can hear me, see me, and hopefully see my screen as well. Tricia, it's been a fascinating conversation so far. I think what Prof. Adeeba has done for us is to tell us that vaccines work, vaccines are necessary, and she's also addressed some misconceptions about the vaccines. And I think all that has been very useful for us to ground our conversation. I think what Dr. Hartini has done for us is to give us a practical reality check, meaning what's happening on the ground is very different from the ivory towers of policy making in Putrajaya, and it's very important for us to consider things like privacy implications. What do we do with the rights of the stateless and not even the stateless, people who are non-citizens and even citizens of Malaysia, and how do we address their concerns in a very practical way, especially as we're trying to vaccinate the last few people in Malaysia. What I hope to do is actually to return to the core of the Liberalism Conference for Ideas today. And in this core is to talk about the balance between personal liberty and also the community interest. And this is a perennial conversation for liberals in the conversations but I guess in the balance between right-wing, left-wing, authoritarian versus more freedom for the individual. All these are very important considerations. I just have this one slide, but in this one slide, what I hope to do is perhaps just to draw three areas that I'd like to spend maybe 3 to 4 minutes on each of these areas. The first one is to talk about the history of liberalism and vaccines and infectious diseases, because it's not just about vaccines, it's about infectious diseases as a whole. Because at the moment, we don't have a vaccine for diabetes, so therefore, we need to start talking about the balance for vaccines in infectious diseases terms. When we look at the history of liberalism, this is on the left-hand side of the screen in blue. When we look at the history of liberalism and in vaccines and infectious diseases, even liberal countries or nominally liberal countries like the United States or United Kingdom have centuries-old vaccination acts. Now, liberalism as a whole is not a very new philosophy. It's only about 300-400 years since I think the 1600s or so, when John Locke came up with the idea of liberalism, mostly to go against the power at that time of kings and God. kings and God in the sense of monarchies and God in the sense of religion. So therefore, liberalism was a reaction against the power of monarchies and religion and wanting to talk about the power and the rights of an individual citizen. But even then, in 1813, there was an act to encourage vaccinations in the United States. And this was only about 40 years or so since they achieved independence in 1776. In 1853, there was a Vaccination Act in the United Kingdom mandating the smallpox vaccine within 3 months for every baby. In 1905, there was a lawsuit by a private citizen saying that the state of Massachusetts has no right to enforce a vaccination on me. And the Supreme Court ruled, the US Supreme Court ruled that states in America can enforce vaccinations. And this was a very important, signal and landmark ruling by the judiciary, not just the executive and not even the legislative. So we see 2 acts of the legislative and the executive, and now the judiciary has weighed in to say that states can enforce vaccinations. And there are also other measures. Forget vaccines. There are multiple other measures to, control infectious diseases. Vaccines is relatively new. I think the first vaccine was around 1750s or something like that. The first one was the Edward Jenner's smallpox vaccine, I think 1753. The point being that quarantines is an Italian word meaning 40, quaranta. Why? Because when they had plague back then in the 1400s, any ship that would come to Venice, which was an important city-state at that time, had to stay at anchor away from the Venetians for 40 days. That's how the modern word quarantine came from, because 40 is quaranta in Italian. We also had, including in Malaysia, leper colonies. Now, I'm not saying this is good or bad. I'm just telling the history as it is, meaning leper colonies existed in Penang and in Sungai Buloh, where we isolated people with leprosy because it could have the potential to transmit to other people. And even till today, in many countries, doctors with hepatitis B cannot work in surgery or in exposure-prone procedures. The point I'm making is that the history of liberalism does not tell us that everyone has full and unfettered, unqualified rights to do anything that you want. Because not only in vaccines terms, but in quarantines, isolation, and restricted employment rights, there are limits to the rights that we have as an individual. And this is not a new debate. This is a debate for 300-400 years already. And we're only in this debate today because of the widespread nature of COVID. So Tricia, this is my first point. My first point is that liberalism doesn't give unlimited rights to the individual, especially when it comes to infectious diseases, and vaccines are only one part of our fight against infectious diseases. Tricia, let me move on to my second point. My second point is to extend the argument that rights are not absolute. We know that. Nobody in this world has any right that is absolute. And even more importantly, these non-absolute rights are even less absolute in healthcare. Let me make a few examples, or rather elaborations. The first one is to say that infectious diseases are not equivalent to diabetes, hypertension, or stroke or obesity. These are called non-communicable diseases because they don't transmit from one person to another. If you have diabetes and you choose not to take your medicine, we can argue that you're only harming one person, and that is yourself. But if you have any infectious disease and you refuse to take your medicine or to subject yourself to some form of restrictions so that you can protect not only yourself, you're actively harming another person. Which is why infectious diseases are not equivalent to non-infectious diseases. Which is why we have things like notifications, meaning if you have syphilis or dengue or malaria or HIV or hepatitis or COVID, you have to notify authorities. But generally speaking, if you have diabetes, you don't really have to notify the authorities because there is no threat to others. In COVID, you have to do contact tracing. But if you have diabetes, it doesn't matter who you meet. You don't have to report that. And which is why when you have COVID, you might need to go for quarantines. But if you have, say, a heart attack or diabetes, you also don't need to go for quarantines because, again, you're not a threat to others. Now, this may seem like a very blunt way of putting it, but the differences are very clear because infectious diseases have a threat to other people, which is why the balance should really be towards community interest and less towards personal liberty. Secondly, Healthcare wants to help people make good decisions. So one might argue that if you have personal liberty, you should also have the liberty to make bad decisions, like smoking, like not wearing a seatbelt, like not losing weight, like eating fatty foods and not exercising. Sure, these are all your rights. But healthcare exists to help you make good health choices. So why should we, if we say that it's okay for healthcare professionals to help people lose weight, wear seatbelts, stop smoking, why should we stop there? Why should we not encourage people, including sometimes mandating vaccinations? Because if the entire ethos of healthcare is to help people make good decisions, then vaccines are a good decision too. Thirdly, is to talk about the balance between rights and duties. Let's talk about this from an individual perspective. What I mean to say is, anyone's rights must be balanced by a person's duties. Your rights are not absolute. Our rights are not absolute. My rights end where your rights begin. Your rights end where my rights begin, which is why, especially in the context of infectious diseases where my rights will threaten your rights or could threaten your rights, it is very important to also note that your rights must be balanced by your personal duties. And nobody in this world has got an absolute right to do anything that they want without any form of corresponding duty. And to complicate matters, Tricia, is to say, what about the rights of companies to refuse service to unvaccinated individuals? Meaning, even if the government says, well, we're not going to mandate vaccines and people can do whatever that they want. If the person believes that every person should have the full right to do whatever that they want, it means that companies might also, should also, must also be given the right to refuse service to unvaccinated individuals. Why? Because they want to protect their staff, they want to protect their customers, they want to protect their business resilience, and they don't want to be a focus for infection. So if we're talking that personal liberty is the most important element and it's a fixed ideology, then therefore, to avoid the charges of hypocrisy, we must also confer the same right to companies to refuse service. Tricia, this is my second point, that rights are not absolute, and they're even less absolute in healthcare. But these are the first 2 points that I've made, Tricia, in blue about the history of liberalism, and in yellow, that rights are not absolute and they're even less absolute in healthcare. These are philosophical. Let's talk about the practical elements right now, because I'm a very practical. And as a practical start, what we can do is to consider that the intentions are important. What I mean to say is, what are the intentions of any measure to reduce freedom? The intention of any measure to reduce freedom, for example, a COVID vaccine mandate, is to protect public health by increasing vaccination rates. It is not to reduce anyone's rights. Now, I bring some good news. The good news is that in states, companies, or even entire countries, so in countries, individual states, or companies that have introduced a vaccine mandate, we have seen an increase in vaccination rates. For example, the state of New York with teachers, so you can read about that. The state of New York in America with healthcare workers. So when they introduce a mandate for teachers and a vaccine mandate for healthcare workers, the rates of vaccinations increased dramatically. A third and fourth example would be companies. Kaiser Permanente is a hospital group in California, seeing their vaccination rates raised from, I think, 70-something% to 99% after introducing a vaccine mandate. The fourth example I want to provide is United Airlines, also in America, because in America, there are a lot of employers and states and even district councils with the ability to introduce vaccine mandates, because America, is a federation as opposed to being a unitary republic. Anyway, the point being that the fourth example I want to provide is Delta Airlines, and seeing the vaccination rates increase from 70-something% to 90-something% as well after introducing a vaccine mandate. So vaccine mandates work by increasing the vaccination rates. The intention is to increase vaccination rates to protect the public, rather than introduce a vaccine mandate just because I want to reduce your rights. So let's be clear what the intentions are. Secondly, and a commentator or a participant today mentioned this as well, we should not focus on the 1%. I absolutely agree. And we're fortunate that the number is 1%. The other 99% of people are very happily receiving those vaccines. Let me give some specific concrete examples. In Malaysia, 97.4% as of today of all adults have received at least one dose of the vaccine. That's a fantastic number. And as we go and give more vaccinations to more adults, we should see that the number of hardcore anti-vaxxers, I'll call them that, hardcore anti-vaxxers could be 1% or less. Now, 1% is actually quite a large number. It's about 300,000, say, population in Malaysia, and I'll talk about that in a second. But let's not focus on that 1%. Meaning, if we focus on that 1% only, we will miss the other 99% that we constantly have to reassure. Now, just for argument's sake again, right? And just to be clear, 97.4% of all adults in Malaysia have received at least one dose. Around the world, 3.8 billion people have also received one dose of the COVID vaccine. And that's a fantastic number. I want to focus on that rather than to focus on the 1%. The anti-vaxxers who are hardcore should not drive our public conversation. Thirdly, and on the in the box on the green box on the right-hand side of the screen, we need to focus therefore on the basket of solutions. For the 99%, not the 1%. For the 99%, make it easy for them to get vaccines, including booster shots. And when I say easy, the vaccines have to be free. For example, when you go to take a vaccine, your company should be giving you a free day, and vaccines should reach those underserved populations, marginalized communities, those who are illiterate, those who can only speak in their native language, those in the rural areas, the undocumented migrants, non-citizens, those who are on day wages and cannot take a vaccine simply because if they don't show up to work, they don't get salary for that day. And frankly, between choosing hunger or vaccines, I would choose not being hungry. These are the people that we have to make it easy for them to get the vaccines. And that's a lot of conversations that needs to be had and a lot of, say, policies that needs to be implemented for these people. All at the same time, education, reassurance, fighting disinformation and fake news, prosecuting those who spread fake news. All these are very important, and we need to continue fighting that fight. And finally, in the basket of solutions, the government should maybe allow or even encourage, not even just passively allow, but actively encourage industry-specific mandates. So for example, if the bubble tea industry in Malaysia all come together and say that they only serve customers who have been vaccinated, I would welcome that. Or banks will come together and say all customer-facing employees in banks will also need to be vaccinated. We should also welcome that. But industry-specific mandates does not have to be a government policy. However, government of Malaysia, for example, can definitely consider making it, say, an actively encouraged policy. Finally, Tricia, we arrived at 1%. This is the hardcore, ideological, fixed mindset, anti-vaxxer that we can never educate anymore. Can't educate, just can't. But I share a few points over here. And the most important point that I share is that the European Court of Human Rights, it is the European Court, right? And this is a continent that has prized human rights, especially after the experience of Nazi Germany. This is about as liberal as you can get. The European Court of Human Rights has ruled in September 2021 that mandatory vaccination programs are not incompatible with human rights. In other words, they are compatible with human rights. In other words, they are even, and I quote here, I need to check my words, may be necessary in a democratic society, actual end quote. Why? Because 30 doctors and nurses from Greece, and Greece has a mandatory vaccination program, sued Greece in the European Court of Human Rights, asking the European Court of Human Rights to ban the mandatory vaccination program in Greece. But the European Court of Human Rights declined to do so and cited those language that I provided to you. So to repeat, this is such a fundamental assessment that a mandatory vaccination program is actually compatible with your human rights. And this is not, for example, the Southeast Asian Court of Human Rights. This is the European Court of Human Rights. And I'm not necessarily pro-Europe, and I'm certainly anti-colonial. The point I'm making is that in a continent that prizes human rights, that privacy is a human right, that human rights are very important fundamental elements of their constitution and their society, especially after the experience of Nazi Germany, have ruled that mandatory vaccination programs are compatible with human rights. That sends a strong message that in the balance between liberty and community interest comes first. I can give a list of other examples of mandatory vaccination programs, and mandatory vaccination programs, these anti-vaxxers which have you believe, right, that they will be forced and strapped and injected against their will. Come on, nobody ever believes that. But fines are okay, and many countries have instituted fines. Many countries have instituted a mandatory requirement for you to access public services. Australia, for example, has a no jab, no pay policy that's been in place for at least 5 or 6 years. What the no jab, no pay policy means is you cannot have child welfare assistance payments if your child is not vaccinated. Seems pretty reasonable to me. And here's a list of some countries in mandatory vaccinations for healthcare workers: France, Italy, Hungary. Mandatory vaccinations for civil servants: Canada, Fiji, California, and the United States. Mandatory vaccinations for home care workers: Australia, the US, and France. Mandatory vaccinations for everyone: Kazakhstan, Micronesia, Turkmenistan, and Saudi Arabia. Mandatory vaccinations before you can move around the country or enter any location like a bar or a concert: Lebanon, Singapore, the United Kingdom, Russia, San Francisco, New York. Mandatory vaccinations for all workers, regardless of industry: Russia. Mandatory vaccination for students 12 to 18 years old, the city of Los Angeles. And again, perhaps, Tricia, I'll end by saying that the European Court of Human Rights ruling in September 2021 is probably the strongest indicator that in the balance of vaccines, right, between personal liberty and community interest wins. I pause here, Tricia, over to you.
Thank you, Dr. Khor. This is fascinating stuff. Keep the slide there for now because I want to ask like 1 or 2 questions on this. Thank you so much for unpacking, what's at the core of this debate and discussion. And this is exactly what we were trying to get at when we put out this theme, especially when it came to vaccinations. I love the fact that you raised the fact that this debate is not a new one. It's just new to us now because we are currently experiencing it. I mean, this generation is the one generation that had not prior to this experienced a pandemic in this nature, in this way. And I love that, you brought up the fact that, this Vaccination Act already had considered these various angles as early as in the 1800s. And you're right, it's not just about vaccinations. It's about other public health measures, right? So quarantines, isolations. In fact, somebody just put in the chat box something about masks. So that might be interesting for us to examine as well. Like, yes, we could make vaccination programs mandatory, or maybe we use public policy to nudge people along, right? There's a very good book on public policy called Nudge. For certain things that you may not want to make mandatory to the public, you may want to create the conditions around nudging people towards a certain better, or what is conceived to be a better overall solution. But would masking be something that you would consider mandatory? Maybe that's something that you can answer. That's one question. The second question that I have was actually very direct. It's just about this 40 people that you mentioned in Greece. Why did these 40 doctors actually request the ban on the mandatory vaccination program? I mean, I find it fascinating that they were doctors and they themselves did not want that. Maybe you can just address those 2 first, and then Prof. Adeeba, I think her internet's really bad, so unfortunately she can't join us right now. But I do want to give Dr. Hartini some time to respond to you as well, because I think you brought up quite a lot of things. Basically, what you're saying in this particular debate is that community interest outweighs personal liberty. I mean, that is your final conclusion. And I think making that distinction in that yellow box over there between something that is infectious and something that's not infectious, that's very, very clear. So maybe if you can just address those 2 questions, and then I'll give Dr. Hartini some time to respond to you.
Tricia, thank you. You've asked 2 questions. The first one is about mandatory masking, and secondly about the 30 doctors in Greece, by the way, so not 40. So I'll take the first one first. I support mandatory masking. Of course, mandatory masking would be within certain parameters. For example, if it's outdoors, then you're less likely to need masking. And if you're indoors, you're more likely to need masking. And I'll make another side note as well, right? To say that human beings and human societies beat cholera in the 1800s or so. We beat cholera without a vaccine. How did we beat cholera? And at that time, cholera killed lots and lots of people. We beat cholera by reorganizing urban water and sanitation systems, meaning the first public health specialist was actually an engineer. I love it. today's public health specialist shouldn't really be an epidemiologist or a virologist. Today's public health specialist should be a ventilation expert, meaning the ventilation engineer. We need a re-engineering and a reinvestment into the way buildings are ventilated right now. COVID will not be the last respiratory disease that's infectious. There will be other respiratory diseases coming soon that will be infectious as well. The quicker we rebuild our ventilation systems, the better. Until then, mandatory masking would be probably a good idea. And indeed, between mandatory masking and mandatory vaccines, it's much easier to push for mandatory masking because the costs are so low compared to the benefits, meaning the cost of wearing a mask is just, for example, the financial cost and also the discomfort of wearing a mask. And the benefits are a lot higher because, or rather very high, because you can really prevent a lot of diseases. But when it comes to, say, mandatory vaccines, and just to compare mandatory masking and mandatory vaccines, one can argue that mandatory vaccines are more difficult to sell. Why? It's more difficult to sell because you're actually injecting a substance into a person's body, and then there could be all sorts of considerations about right to bodily autonomy and the person's right to bodily choice and things like that, which makes it a little bit more difficult to sell. Nonetheless, Tricia, perhaps I wasn't clear, or rather I didn't state this earlier, so allow me to state this. I do not believe that there is a need for us to do super mandatory vaccinations for all 100% of the population. I don't think we need that nuclear option law. However, we can have a series of options, the nudges that you mentioned, to create a choice architecture to make it so difficult for people that they will ultimately end up taking the vaccine. And if you're an ideological, hardcore, fixed belief, never change, anti-vaxxer, then you know what? We'll try to reduce the numbers to as few as possible without having to create a nuclear option of a law, because these numbers will actually be very, very small. And if they can survive and not having their liberties, because frankly, they would be a risk to other people, then I think this would be an acceptable compromise. That's my first answer to your question, Tricia, which is about mandatory masking, which I judge to be a good public health tool with very little cost and much easily sold compared to a mandatory vaccine. Secondly, it's about the incentives of the Greek doctors. Now, I don't know how many doctors and healthcare professionals that they are in total in Greece, but let's assume that the number is quite high. 30, therefore, represents an extremely small minority of the total number of doctors, nurses, pharmacists, paramedics, allied healthcare professionals in Greece. And these, well, as with all professions, there would be anti-science, even in medicine, unfortunately, there are a lot of doctors out there. When I say a lot, right, it's still a minority. So that's, I'm very grateful for that. So I think that these are a fringe group of people and should not be taken to represent the entire Greek healthcare professions. My first point. Number two, their reasonings are the standard ones that you might expect. It's a right to personal freedom, and it's a right for people who to make their own choices. We think that the vaccines have not proven efficacy and so on and so forth. Again, these are likely to be a very small fringe of that will be present in any society, including the healthcare community. And those are the reasons that they mention. I'm only reporting the reasons, Tricia. I'll state categorically that I do not believe those reasons, nor do I support them.
Okay, thank you so much, Dr. Khor. I know that you have to leave us like soon, but I want to actually, I'm going to address, like, there are two questions that are addressed to you directly. So I'm going to read them out first. But I think it's also tangential to what you've already been saying. So if, as promised, I'll give Dr. Tini some time to respond and then go back to you before you need to leave. And then I'm so glad to see that Prof. Adeeba is back here, and sorry that you were not able to listen in for the last 15 minutes or so. So one question from Jingmin Wu is, okay, so he says, directed to you, to my knowledge, natural immunity against COVID is often better than the vaccine, and some may choose to make that their good choice. Shouldn't they have the right to make that choice? And another anonymous attendee is saying that only maybe just because European countries ban access of public access to anti-vaxxers, it doesn't mean it's right. And the fact that vaccination doesn't fully prevent transmission makes movement restriction to anti-vaxxers unjustifiable. So I think that basically goes into the question about, basically vaccinations don't fully prevent transmission. And therefore, is that fair to restrict the movement of anti-vaxxers? So Dr. Hartini, you can respond to Dr. Khor, or you can respond to some of the things that I just said, maybe just for 5 minutes, and then I'll pass the time back to Dr. Khor before he has to leave.
Yes, except that I don't know what the question was. Sorry. What was the question again?
Well, no, I actually wanted to give you time to respond to what Dr. Khor was saying as well, because he kind of presented this very useful framework about, in the sum of it, he's basically saying that, you know, community rights trump personal liberty.
Personal rights. I absolutely agree with him, except like I said, I don't think there's a hard black and white definition of why, of who anti-vaxxers are. And I think we can persuade people to get vaccinated if we give them more information and we try to address the issues. And there are many reasons why people are not getting vaccinated as well. And the hardcore true anti-vaxxers, the ones that Dr. Khor is talking about, I think are very few, but they're loud. And they're loud on social media. And they're the ones causing a lot of harm, I think, by spreading misinformation and disinformation. But, you know, people like my friends, for example, are asking questions and hesitating. And I don't think we should be putting them as, you know, I would never call her an anti-vaxxer. I would never call her friends anti-vaxxers. They just want more answers and more questions. And I'm saying it can take time. But I totally 110% agree with what Dr. Khor is saying. I'm just saying it's not anti-vaxxers versus privacy. It's a privacy issue. I'm just saying they want more answers.
Okay, Dr. Khor, do you want to respond to those two questions that were addressed to you?
Sure. Tricia, there is essentially one question, and the question is, shouldn't we have the right to make that choice? When they say we, or when I say we, it means those who choose not to have the vaccine. So I'll try to answer that question by going into some detail. I hope you can all still see my screen. If not, it's in the question and answer section of the Zoom chat. The questions by Jingmin Wu sent at 2:59 p.m. And I'll unpack this one by one. To my knowledge, natural immunity against COVID is often better than a vaccine. Not true. We don't have enough data to show that natural immunity against COVID is better. And we can still say that for an uninfected person or a COVID-naive person, the vaccine will be much better than getting COVID. So it's not true to say that natural immunity against COVID is often better than the vaccine. So Jingmin, this is the first thing that I'll say to you. The second thing I'll say to you is some may choose to make them their good choice. This is your words, Jingmin. Now, I'm not trying to say use your words against you, but the inference from your words is if some may choose to make that their good choice, are you implying that they will choose to get COVID? In which case, I suggest let's try not to get COVID, because COVID and earlier on in the COVID pandemic, there have been some COVID parties, which was proven to be a terrible idea. A COVID party was when you would go to a party with people with COVID, and then you hope to get it so that you can have natural immunity from it. Now, it's been proven, Jamie, that that's a terrible idea, because if you have COVID, you are quite likely, or not quite likely, but you have the risk of getting severe disease, or to be hospitalized, or to be ventilated. So if given a choice between getting a vaccine or getting COVID to reach immunity, we should always choose the vaccine to get immunity. Thirdly, Jingmin, to answer your question directly, shouldn't they have the right to make that choice? I would say, yes. I'll answer your question directly. Yes, they should have the right to make that choice. But, Jingmin, fortunately, very few people are making this choice. Because fortunately, 99% of the people who are offered this choice of a vaccine, after adequate reassurance and knowledge and information, are choosing to get the vaccine. So fortunately, only 1 or less than 1% of people are exercising the right to make that choice. Secondly, Jingmin, I would say that while you have the right to make that choice, or these people have the right to make that choice, you do not have the right to spread fake news. You also do not have the right to spread disinformation. You also do not have the right to spread fear. So while you have a right to make the choice to not take the vaccine, you should keep this choice to yourself, because, well, it's all about privacy and your privacy is important. Therefore, you should keep your choice of not taking the vaccine to yourself. but certainly not to spread fake news or lies or any disinformation, and certainly not to spread fear. I think you'll agree with me here. Finally, to the question of do we have rights to not take the vaccine? I repeat my answers. A lot of people are choosing to take the vaccine, 99% of people. So you are in the minority. Number two, while you may have the right to not take the vaccine, we still encourage you to take the vaccine. We still think it's a good idea for you, and we hope that you will change your mind. You have the right to not take the vaccine, but not the right to spread lies. Thirdly, and finally, is to say that if you have the right to not take the vaccine, equally, other people will have the right to, for example, not extend service to you. If I'm a company and I choose not to extend my services to you because you have been unvaccinated, I don't let you into my restaurant or a bar or a concert or to purchase my services, it's also within my right to not extend my services to you. So your rights are not absolute, the same way the rights of the company are not absolute. So this is why it's important for us to meet in the middle to balance. So to the question of, do you have a right? Yes. A lot of people, or rather everyone has almost always has a right, but that right has to be balanced with duties and also with consequences. Tricia, I'm going to pause here, over to you.
Okay, thank you so much. I think you can also stop sharing your screen. Thanks for your responses to the questions. Actually, I want to go back to Prof. Adeeba, who's back now, thank you. I want to pose a similar question to actually like what we've been talking about the last 15 minutes or so, which is precisely about this, balancing of the personal and community rights, personal rights versus community interests. So there was actually a discussion amongst our own staff as well. While we were talking about this particular panel, we were quite, excited about it. And so Dr. Khor talked about the rights of companies to deny services to unvaccinated people, because companies, they, as you said, want to protect the health of their own service workers, their own staff, and they don't want to be known as the source of a cluster, right? I mean, ultimately, that's basically it. I mean, we have had that thought as well, right? If we were to organize events, we don't want to be known as the ideas cluster. That would be very disastrous. But how about government? So maybe I can pose this to you, Prof. Adeeba. Can and should the government deny services, public services? So let's say, I don't know, postal services, going to apply for your passport, your IC, your driving license. Can and should the government deny such services to unvaccinated people? And one level up would be, can and should the government deny public health care services to those people who get infected and have chosen not to vaccinate themselves? So yeah, Prof. Adeeba, what do you think?
Yeah, first of all, apologies. As I said, I feel like I'm in a third world country, but I'm actually in Berlin at a hotel given to speakers of the World Health Summit, no less. I don't know. I think it's just a room that I'm in particular. So in terms of denying the access to health, that's obviously a red line. I mean, I think no one in their right mind, in healthcare professionals, would deny, much as we get annoyed and angry and, are fatigued at looking after people who get infected with COVID-19. It's something that we just don't do as healthcare professionals, right? Tempting as it may be sometimes, but we that's certainly against everything that we were taught. So never fear that you will still get the best care, even if healthcare professionals are just humans and will show our annoyance because we've all been struggling with this pandemic for a year and a half, and to have something that can prevent that and you have elected not to is just it's just annoying, right? I know my nurses and doctors who are treating patients will give you an earful when you come in and you're not vaccinated or you've not been vaccinated, but they will still give you the best care. they will nag you to to then have the vaccine upon discharge. Now, in terms of accessing other services, I think again it is what is currently being practiced in the private sector is game for the public sector as well, in terms of not allowing. I mean, I don't think you should be once again denied things like a passport, but I can tell you right now that you're not going to be able to go anywhere without a vaccine, right? I have just had to jump hoops, and at every checkpoint they will want your vaccine passport in immigration. So you're not going to be able to leave Malaysia full stop if you're not vaccinated for a long time, unless you have a very good reason. But in terms of entering buildings and continuing your work, I think it's fair to insist that you have regular COVID-19 tests to make sure that you're not harboring the infection. So if you refuse vaccination, then a weekly test or even twice weekly test is, I think, a reasonable alternative for those who still refuse to be vaccinated. And those tests are unpleasant and cost money. So like what Swee Kheng was saying, it is about protecting others around you, because there will be people where the vaccine is not as effective as it should be, and will remain at risk even if they're vaccinated, and as well as children whom we haven't started vaccinating yet.
Thank you, Prof. There are a few questions from Facebook which are quite similar to each other, so I'm going to try and group them. And if Dr. Khor, you need to go in the middle of your answer, or maybe answer 1 minute and then please go ahead. So the question is about like data about how the number of cases actually dropped. So I think this is really important to unpack, because as far as I know, there hasn't really been a clear reflection and reason given to how things drop. I mean, was it because suddenly the Delta variant became less efficacious? Was it because the vaccination rate started to improve, or so many people have already been infected that's why it dropped? So these are the actual questions. So is the lower number of cases due to lesser testing? Yeah, so that's also another reason. So basically you have like an array of reasons, right, for why the cases have actually dropped in Malaysia. A second similar question would be, will we be able to achieve herd immunity when our fully vaccinated reach a certain rate? So again, like, is it the vaccinations that are going to allow us this reduction in cases? And another question, also similar. So the person says, I'm pretty sure the cases didn't really go down dramatically when people were starting to get vaccinated. But then the high cases were said to be high because of the backlog. I'm not sure whether the person means like back then the high cases were said to be high. So I think there's also a lot of like, there's not enough knowledge and unpacking of the data, like what caused the spike, what caused the drop, right? Like which factors most contributed to these changes in trends. So I would open that to Dr. Khor first, maybe before you leave.
Thanks, Tricia. I'm actually very glad that Prof. Adeeba is here, because I think her answers will be a lot deeper and more nuanced than mine. To answer the question directly, what caused the drop will probably be it's multifactorial. It's a factor of the vaccinations protecting the most weakest of our society, as in immunologically the weakest and the ones that are most higher risk. Number two, what causes the cases to drop is probably because we did have a period of some form of a lockdown. So the lockdowns were gradually relaxed as we move from phase 1 to 2 to 3 to 4 of the National Recovery Plan. So that's the second reason. The lockdown was the second reason why the cases were dropping. And the third reason why the cases were dropping is because at some point the community's immunity increases as a function of the number of people who've been infected. That's like more than 2 million people in Malaysia already infected, plus vaccinations as well. So the virus finds it probably a bit difficult to find places to propagate. However, these are multivariate factors. In other words, there are very many factors that explains the drop. One hopes that the drop in the number of cases is not due to under-testing. And it's nice to see that our share of positive tests is getting lower as well. It'll be nice to see more transparent data in the form of how many PCR and RTK tests are being done and what's the percentage thereof. And hopefully to also see that now that we're moving towards self-testing, home testing, and a lot of penilaian kendiri, which is a self-assessment, which is great, that the reporting will be accurate and truthful, that we're not hiding positive cases and still going about our daily business. Tricia, maybe I'll pause here and then over again to you. Thank you.
All right, Dr. Khor, thank you. Prof. Adeeba, if you may want to respond on that, and then I'll also give Dr. Hartini a chance to share some of her views. Prof?
Yeah, thank you, Tricia. And I concur with Swee Kheng's explanation for the drop in cases. It's unfortunate that there's been, kind of confusion and mistrust in the government data. But I can tell you that the drop that you're seeing in the graphs, in COVID now, in the MOH data are real. It is also what we're experiencing in the hospitals in terms of bed closure, the entire 13 floors of PPUM were basically turned into COVID wards, and now we're slowly closing those wards and returning them to other disciplines. And as Dr. Khor said, one is, of course, the effect of lockdown. But if you recall, unlike the first lockdown, we didn't see measurable drop in the number of cases for many, many months, unlike it was in the first lockdown. And the reasons for that are also many, but speaks to the high infectiousness of the Delta variant. And it was only when we reached I would say a 50% percentage of vaccination in Klang Valley that the numbers then started to drop. I have no doubt in my mind that the effect of the vaccine is what led to the drop in cases, and this has been shown all over in the data from the UK and the data from US, and that correlates the vaccine coverage and the drop in the number of severe cases, deaths, and hospitalization. Okay, so that's my take as well on the correlating vaccine coverage and a decline in number of infections.
Right, thank you, Prof. Dr. Hartini, would you like to respond to maybe like how, comments, or maybe like from the community side, is this the perception that they have as well? Some of the questions that have been coming up?
Absolutely. I mean, I'm sitting here listening to Dr. Khor and Dr. Adeeba and wishing to God that we had videos of what Dr. Adeeba says and videos of Dr. Khor that we can translate so that we can send it out to the community, because it's so reassuring. I think much of the vaccine hesitancy was because people didn't know, and nobody was transparent in giving information or reassuring the communities and addressing the fear that so many people were facing, and we didn't know, which was why I think so many people went to social media and so many people were spreading all this misinformation. Nobody told us, and nobody told the communities anything. So I'm sitting here hoping that we can take this session, get it translated and send it out to the community, especially with Dr. Adeeba and Dr. Khor addressing the very fear that's very real still in communities. And I'm hearing it as of yesterday. So I think what this session is really important is that documenting and recording this and getting the content translated.
Sure. There's something else that I want to unpack as well. So vaccine passports, right? So I think Prof. Adeeba, you've just traveled and you just said that, if you don't have a vaccine passport, you're not going to be able to leave the country. What?
Not at all.
Right. Yeah. I think this is, I mean, like it or not, this is the way that the countries have all adopted. And yeah, if you want to leave and if you want to cross borders, this is something that is going to be the case for many years from now. What do you think that that is the right approach? So that's one. And secondly, I want to ask about some people who actually believe that if they are at risk of basically having a weaker immune system. So, for example, cancer patients, like would cancer patients with weaker immune systems be discouraged to take the COVID-19 vaccination? And if so, how do we legitimize or justify the existence of such vaccine passports, whether it's for travel or whether it's for entering premises and so on?
Yeah, so it's the issue with the immunocompromised, whether they have cancer or whether they have or whether they've had transplantation, is that the level of immune response is not as robust as someone who doesn't have the underlying disease. It doesn't mean that they shouldn't be vaccinated. It may mean that they may need more frequent doses. So in essence, someone who with transplant or someone who has cancer we don't even call it a booster. They need a third dose to mount an immune response that someone who doesn't have these underlying conditions do. So, and this is not uncommon. This is not unusual, okay? For hepatitis B vaccine, for instance, we do recommend that, people who have transplant or underlying disease may need an extra dose compared to someone without those conditions. So it certainly doesn't mean that you shouldn't have it at all. In fact, you should have more doses, not less doses. Now, in terms of the vaccine passports, once again, it goes back to we've seen the devastation that COVID-19 has wrought all over the world, right? And we have a tool that can fix that. It's not 100%, but it's damn good, in fixing, in returning life to normal. So why shouldn't we make sure that only those who are at low risk of having infection and transmitting it to others, particularly bringing in variants that may even be worse than Delta, I think countries do have a right.
Okay, great. So basically from the medical point of view, immunocompromised people should actually be taking the vaccination, in your opinion, more than?
No, so the data for that is still coming through, but for definitely for transplant patients, we have data for that, and we know that they need a third dose, right? And whether they're going to need a fourth dose in future, well, that remains to be seen. But these are things that we need to continue to study.
All right, thank you so much. I think as we learn more about how the virus operates, somebody also just asked, oh, is this like a Windows update, right? Like a virus update on the computer where you have to keep getting additional boosters or additional vaccinations in time to come.
It's just that in Malaysia we're not doing it routinely, but remember the flu vaccine is something that we are recommended to do annually. So again, it's nothing terribly unusual or something that Bill Gates is propagating, since someone mentioned Windows Update.
Okay, all right, thank you. So I think we are kind of like about 15 minutes to our closing. So what I'll do is maybe I'll just like take one final round of questions for myself or whoever has asked here. I'll try to just go through these, get your responses, and then I'm going to ask each of you to close, and in the closing remarks, maybe think about what you want to say to the Malaysian community at large. Like, I think where we are now, we are, like I said, we've kind of gone through that bump. We seem to have a more relaxed situation now, but who knows what is to come. So anyway, let me get through this final round of questions. So there's a question about why did we stop announcing the breakdown for the number of infections for fully vaccinated? We have to be transparent about this, like other countries. Singapore shows the breakdowns. So yeah, I think this is about data transmission, transparency and disclosure. I think that's something that Malaysia has to do better.
Maybe I can take that question.
Sure,
yeah. So you know, one of the problems with data is, you know, it is not that easy to collate. Okay. A lot of and I think YBKJ is trying to fix this in terms of making things automated, right? If you can imagine, you know, how many hospitals are there in Malaysia, right? And so each hospital will have to report to a central what do you call it, the CPRC of the new admissions, who are the new people who've been admitted, have they been vaccinated, how many doses, which doses they've been vaccinated with, are they category 2, 3, 4, 5. So if this kind of data collection is not automated and done manually, it is a nightmare, first of all, as someone who oversees the collection of, you know, at the ward level, for doctors or nurses to fill in the forms. That's number one. Number two, it is also a nightmare that the central part to try and clean up this data, collate it, and put it out in a meaningful way. So I'm not saying this as an excuse, but, you know, it is something that, you know, I've been calling out for the automation, digitization, automation of data, and this is why we need it. You know, I don't think it's about trying to hide anything. It is really a laborious manual process currently. Singapore has, I think, 7 hospitals. We have, I don't know how many 100 over hospitals all over the country. Yeah.
All right, thank you. You're right about collating data. I think that's something that we tend to forget. This exercise itself is a gargantuan task. But nevertheless, I mean, I think the new website does do a better job at providing data and information in disaggregated ways that were not being done previously, right? So I think that's something to be thankful for. I think I'm just going to read out just one or two questions. So there's one question here about if the virus has been studied for a long time, what made them unable to develop a cure instead of making this a vaccine? I think, well, I mean, from my limited understanding, I don't think the virus was studied for a long time. I think what Prof. Adeeba was referring to was the mRNA technology was studied for a long time, not the virus. The virus was, you know, emerged relatively new. That's why it's called the coronavirus, right? And what made them unable to develop a cure? I think, well, again, I'm not the panelist here, but the vaccine itself is a scientific way of ensuring people get mild forms of infections. The second question about if it's 95% vaccination response in our community now, what's the reason that we have on the 5% of reluctance? I think Dr. Khor actually addressed that earlier, but if any of you want to talk about it. And then another final one here is, I won't read the whole question, but the question is basically, is the Malaysian government having a tacit belief that the country can never go back to life as pre-pandemic normal? And what are we to do about this? So maybe Dr. Hartini, in addition to these questions, maybe if I could ask, like, what do you think it would take for the community the communities that you regularly work with? What would it take for them to be convinced to increase this public trust? I think what you said, there was a huge, erosion of public trust. What would it take for them to overcome that? And for them to, adhere to the requirements that what, the government is trying to put forward in interest of community at large?
Well, I think the first and most important thing is to get one policy and one articulation on who needs to get vaccinated, and to demonstrate that the priority is vaccinating everyone and not detaining some. So that would be nice. Actually, it would be more than nice. It's the most important thing. We're not aligned. You have the Minister of Health saying one thing, let's vaccinate everyone. Then you have another ministry and minister saying, we're gonna detain you. So if we can align both and say, look, and answer the question, what is the priority in this country, and who exactly and what exactly is the national security threat, then I think a lot more agencies and communities and people and NGOs working with them would feel a lot more relieved, because we know then that we can trust the government to actually follow through with the promise they make. Right now, we don't. We're still not sure. So, the Minister of Health can say, please come out, let's vaccinate you. And then, then you see these raids. So let's align and reassure the public at large, including the communities, that the priority in this in combating COVID-19 is vaccination, and vaccination of all. So I think that's the first thing that needs to happen. The second is, if we can get people like Dr. Adeeba and Dr. Khor to make these documentaries and get that. Honestly, you have no idea, even as me who sort of knows what's going on and stuff, even me, I don't know, and I'm the layman as well, right? I am hearing and getting reassured by listening to experts like Dr. Adeeba, whom we trust, the experts like Dr. Khor, whom we trust, to tell us the truth. And it's been a roller coaster in terms of sort of, extracting who's telling the truth and what's going what, and who can we trust and who do we trust. So I think if we have more experts like Dr. Adeeba, Dr. Khor, and the Minister of Health aligning and saying, this is what you need to know, we can then just also disseminate the information to combat what's being said and all these conflicting policies and statements. And also that would help with the education and awareness, right? And getting them translated to the dialects of the different languages, etc. And 3, also to remember that marginalized groups are not just non-Malaysians. Marginalized groups are also our Asli and everybody else who also are having issues, right? So I think it's very important that we sort of keep at it, not brand everyone as anti-vaxxers, because I don't think everyone is. It's the hesitancy and the trust. So if we do all this, I think we do a better job, and you can see more numbers of people vaccinated and children.
Thanks, Dr. Hartini. I mean, I think that's a great idea. In fact, I was also surprised that I did not see like some of these very public relations, like PR marketing style things. I think we saw some billboards perhaps on the roads, but then, people weren't really going out anyway. There was a lockdown, so billboards perhaps not so helpful, but I think social media sort of videos, those types, like we didn't see that happening, which could have been useful. I remember the government did that when they were trying to introduce GST, for example. So they had like a huge PR campaign. They had like little videos that were going around. So I think this is something that could have been done. I mean, like you said, translated into the Orang Asli languages as well, right?
But just to give you another example, right now they're saying, oh, we're opening out, the numbers are going to start going up. And so the fear comes back, right? We should be nipping this in the bud and saying, look, this is not true. This is what you need to do. This is how you combat that information and misinformation, and tell people, this is the time to be more vigilant. Instead of just saying, this is the time to be more vigilant, and tell people how, remind people how, do all these different, things. Get Dr. Adeeba to go do all these different things and sort of address these things. But it's starting again. You can hear it. You can feel it.
Yeah. I mean, it's true. And I think, KJ already, Minister of Health, already said, these things. But what you're saying is right. Essentially, what you're saying is we need to learn from the first few waves of COVID over the last year and a half, I mean, more actually coming to 2 years soon, it's not a new phenomenon. It's something that we must learn from our past errors. And perhaps in the next wave to come, if there is one, how can we do better at educating the public about the need, right, for vaccinations, or that vaccinations are one crucial chink in the whole, value chain, as it were, of infections. Prof. Adeeba, do you want to respond to some of the questions that were raised earlier, or also to what myself and Dr. Hartini have been talking about? And then we should try to come to a close soon.
Yeah, I'm sorry for the background noise. I am in the lobby and it's getting more busy. Yes, I think the mixed messages, particularly for refugees and non-Malaysians, didn't help in terms of reducing the actual fear of coming forward to get the vaccine. So I completely concur with Tini there. And also in terms of, like I said from the very beginning, in terms of us reaching out with awareness and education campaigns in languages that's understood, or in making that science more accessible and more understood, and really addressing the fears that people had. We could have done better. I think so. Many of us tried to do it as individuals or as members of healthcare societies, but it wasn't done in a concerted manner, like a really well thought out strategic campaign. So lessons learned there. But I think everyone all over the world is struggling with how to overcome the misinformation and disinformation that is going round. It's just extraordinary, actually, the level, and it's not it's not just the makcik and pakcik in the kampung. It's usually very well educated people who are taken in by the half truths and the pseudoscience that get sent around. I mean, nowadays, when I get sent a really weird message, the first thing I do is check where that website is coming from. And whoever sends it to me, I will just send them the link of the website that more often than not says it's a right-wing conspiracy theorist. I don't know why they just don't go to more credible websites. For people who are still in doubt, do go to credible websites like the WHO, like the US CDC, and even some of the more highbrow journals have very good FAQs for the public on vaccines.
Yes, thanks, Prof. Adeeba. I think this is quite an important case study in the rise of social media's ability to spread news or fake news or misinformation rather deliberately, actually. And so
yes.
This has been a classic case. I think all of us have contended with this, even with our own relatives in many cases. So it's been an interesting time for us. But time is running out. Can I maybe just ask each of you to summarize your thoughts in 1.5 minutes? And then we'll close. So again, thinking about this bigger topic that we've been talking about, balancing personal liberty and community interests with regard to the vaccination. So Dr. Hartini, maybe first.
Lessons learned moving forward. I think there needs to be a concerted effort to sort of combat this misinformation and disinformation. The government needs to align their policies in one person, one voice decision about what is important and what exactly is the national priority in terms of combating COVID-19. And that if the number one importance is to get everyone vaccinated, then that's what needs to come first. not detaining and threatening people. That we also need to be more sensitive to community needs and community information, that there needs to be a more concerted effort to ensure that as many people as possible get the information that they need and to answer questions, town hall meetings, etc., to sort of allay the fears of many people who are not anti-vaxxers, I think per se, but just have a huge sense of vaccine hesitancy. I do think Adeeba and SK should be out there leading the charge and reassuring the public, together with the Minister of Health. I think more discussions like this is very important to get it not to people like us in Klang Valley, but to the people out there who need answers. You know, I wish you could take this to Kelantan or Sabah or Sarawak, because they need to hear this. So that's my thought. You know, yeah, I guess that's where we are. I'm going to leave it to the experts.
Thank you, Dr. Hartini. So for you, like horizontal coordination amongst the ministries, having greater public campaigns, PR, public education, and then the community contact points would be important.
Yeah, people they trust to say what needs to get said. Yeah.
Public trust. Okay, Prof. Adeeba, your final thoughts?
So Tricia, I'm going to take this opportunity to directly address anyone in your audience who may still be hesitant about the vaccine. My plea to you is to really reassess the situation, get the information from credible people, from credible sites, because billions of the vaccine doses have been given to human beings all over the world. There's an entire continent of Africa that has not been, or only less than 10% of people who are being vaccinated and who are desperate for the vaccine. And here we have extra doses of vaccine, and there are people who don't want it, you know, and it, you know, I'm tired, my colleagues are tired. We just want to get back to normal. We want to be able to look after non-COVID patients. And, you know, here you have, you know, nothing short of a modern miracle in terms of a vaccine that's been produced under 1 year that has really changed the nature of the disease. It's not perfect, but it's damn good, you know, and to have people who, you know, question it based on incomplete information or incorrect information, it's really frustrating. I think, you know, enough is enough. The pandemic has caused enough damage to the country, to individuals, to, you know, to the world. Do your bit in terms of learning about what is true and what's not true, and, you know, talk to people who know, rather than believing in WhatsApp messages and fake sites, because, you know, it's and please, you know, stop propagating inaccurate information. That's all I have to say.
Thank you so much, Prof. Adeeba. We really look forward to making sure that the next round, if there is one, we touch wood, we hope that this will not occur again. But I think, you know, the world will not see the end of pandemics as a whole, right? We must use the lessons learned from the last 2 years to do better, as not just a community, as a country, but as a world as a whole. And thank you for being with us on this journey. With that, I would not just like to close our panel discussion for today, but also to close the entire Liberalism Conference over the last 2 days. We really look forward to holding our 7th Liberalism Conference next year in person. And we hope that we'll be able to have like a much more lively discussion with all of you in a hall seated together and not on the screen. Thank you so much, and do continue to follow our work at Ideas. And Prof. Adeeba, safe travels to you. Dr. Hartini, see you soon, hopefully. Goodbye,
Thank you,
everyone.
Tricia. It's a wonderful session.
Thank you.
Bye, Adeeba. Safe trip back. Bye.